And thanks again to the organizers of this for having me come all this way to your beautiful city. I just want to clarify the title of my talk I didn't make clear, I guess, to the program. So it's actually intensivist staffing in the ICU. So if you were looking forward to intensive staffing, I wasn't planning to talk about that, but maybe in the end, if there's something related to that you guys want to discuss, I'm more than happy to. So I have no conflicts of interest related to this. In the next 30 minutes or so, what I want to kind of take you on a tour of is what we know about intensivists and how we can use that information in terms of staffing our ICUs cleverly, at least in 2018. And I think to do that initially, we need to go over what we know about the impact or the importance of intensivists. And then ultimately, we'll get to how can we use that information to learn how they should be staffed and where to go from here. So I just want to start this with a reference to a study that I think many of you are familiar with. This is a study now published about 18 years ago in JAMA, led by Derek Angus and colleagues, in which they looked at across the United States and identified that in the late 1990s, only about a third of intensive care unit patients actually ever came in contact with an intensivist. And I realize this is US-specific data, and obviously from country to country and from region to region, we have variability, but it is my understanding that there's significant shortages that are not uniquely a US problem. And actually what they predicted, which I think many of us feel that we have seen, is actually a worsening of this shortage over time. So that not only would 1/3 of patients be seen by intensivists, but as our population aged and became more chronically ill, this would actually worsen. And as a result of this, I think there have been many ideas proposed for ways that we can address this shortage. I should say that there is definitely some debate. I think many of you who know the US context are aware of the fact that many of our ICUs don't look like yours. We have a lot of patients who are potentially less sick than you may see elsewhere in the world. And one could argue that maybe those patients need not be in the ICU, but at least for the moment they are. And so how should we care for them? And so these are just some examples. About 15 years ago now, there was effort put forth to the use of emergency medicine trained physicians, and were finally granted accreditation to work in our intensive care units. More recently, there's been a recognition that hospitalists or general medicine trained, primarily hospital-based clinicians were actually, whether we wanted them to or not, providing most of the care in the US for ICU patients, and so whether or not we should formalize that process and provide them more specific education for critical care. And then two other ideas that actually are credit in large part to Dr. Buckman, who we'll hear speaking about something different in about 30 minutes, have been this idea that maybe we should look for the provision of critical care by non-physician trained critical care providers or advanced practice practitioners. In the US, that would be primarily physician assistants or nurse practitioners. And or should we outsource it and have telemedicine or tele-ICU coverage to sort of address this intensivist shortage? But I think when we think about what an intensivist is going to bring, whether it is brought specifically by a senior physician trained in critical care or any of these other potential strategies, many of us think of procedural skills, but I think most of us realize that's probably something we can train other people to do. And probably the more important thing that we bring, what we hope anyway, is education and experience-based clinical judgment, and then ultimately an ability to help improve the care of critically ill patients across the system by improving patient flow and improving triage to the ICU. And I think up until recently, there was a very strong meta-analysis a few years ago, published by Dr. Wilcox and her colleagues in 2013, in which they looked across the 34 published studies at the time and found that as they expected, although there were some outlier studies, there was overall a significant improvement in the outcome, specifically hospital mortality, in patients in units cared for by intensivists or led by intensivists. And specifically what they looked at were ICUs in which the care of patients was transferred to the intensivist or for whom there was a mandatory consultation with an intensivist, recognizing again that since many of these studies were done in the US, there is not going to be an intensivist available to be the primary provider for all patients. And this was sort of I think we all felt good about this answer and this conclusion until these two studies came out over the last 2 years. And again, they're going to be US-based studies, so they're going to have the US context that we should keep in mind. But in both of them, they look at a more current cohort. On the left-hand side is a cohort of about 49 hospitals in the US, in which they found that the provision of care by a daytime intensivist had no effect on hospital mortality. And on the right, a cohort of about 500 US ICUs when they looked at patients above the age of 65, so patients who were receiving care through Medicare, which is our major elderly insurance provider. They actually found that when hospitals and ICUs transitioned from not having an intensivist during the daytime in 2003 and 4 to having an intensivist during the daytime in 2009 and 10 compared to those who continued not to have an intensivist available, there was really no difference in the outcomes for those patients. And so I think this then calls into question that meta-analysis, but we really should keep in mind, and I would imagine, again, the context of your ICUs are going to be different. Many of these ICUs were what we would consider our more community hospital ICUs in the US, where again, these are not going to be populations that you're used to seeing in your ICUs. They're not going to be nearly as sick, and we'll talk about that in a little bit. So I think there's still a bit of question about whether or not intensivists change practice, at least in all settings. I'm going to tell you that going forward, we're going to work under the assumption that we do. Okay, we're going to work under the assumption that we provide additional optimal care, and so with that assumption, how are we going to staff best with our limited resource? So moving on to intensivist staffing, which is supposedly, again, what this is about. I want to sort of turn on its head the way I think we often unintentionally think about staffing. I think usually we say, well, I have 5 ICU doctors, and this is how many ICU patients, and this is how many days of the year they need to cover, so their workload is going to be however many that is divided by 5, right? And what instead I want to focus on is, let's figure out what we think the optimal workload should be, and work backward from there to try to see how we should staff things. And I want to show you what little data there is to support that. So again, before we get to that, I think when we talk about intensivist workload, we are all aware, but I just want to highlight for us that we're not talking about the impact on just the patient, that there are many stakeholders that probably care about the intensivist workload. First and foremost, for all of us, it is the patient, and if we do find that patient outcome is affected by intensivist workload, then that clearly is of importance to us when we think about staffing. I think probably second to the patient is the physician, him or herself. I think we can all imagine the weeks where we've been very busy and quote unquote overworked, and our quality of life may suffer as a result. And conversely, when we're underworked, we may be less stimulated. And so there may be reasons why it matters to us. But it's beyond the patient and the physician, right? The ICU team is probably affected by the workload of the intensivist. Certainly, they are affected by their own workload, but they're also affected by the workload of the intensivist, how available that person might be to address their needs. And certainly the family of the patient who would like the opportunity to speak with us or see us involved in their family members' care. And then I think in many situations, it's actually the hospital administrators, the regulators, or the government who are interested in intensivist workload, because it would be very nice for us to say that the workload should be some certain amount, but we have to figure out how we're going to actually afford that, right? Okay, so then maybe we can ask the question of, is there an optimal workload? And we'll kind of figure out what data there is surrounding this. So I've just put a hypothetical graph here, where on the x-axis we're going to go from underworked, however that's qualified or quantified, to overworked. And I just want to demonstrate, I think, what we all know, that there are going to be different stakeholders who are going to have different opinions about how workload will affect. So for instance, an intensivist's satisfaction may be minimal when he or she is underworked because they're not particularly stimulated. They get more interested as they have more to do, but then they get less satisfied as they become overburdened, right? You can imagine that. Similarly, you might imagine an intensivist from the perspective of his or her salaries, and many of our institutions, at least where I'm from, are based in a sense on how many patients you see. You might imagine that above a certain point, your salary is going to go up, so you might care about that. It may be the case, and I'll show you in a little bit that it's not entirely true, at least from what little data we know, but it may be the case we might imagine that patient outcomes may be affected by workload, and in fact, patient survival may decrease the more work we have to do. We can sort of imagine that. And then lastly, I put on here, if I can, I put on here whether or not the hospital administrators, the people who are paying for the intensivist, right, how they feel about this. And probably they're really happy the more work we do, right? They need fewer of us. Right, so that's, you can imagine. And I only put this out here to highlight that even if we were to try to optimize workload, optimize it for whom, right? There are going to be many different stakeholders who are going to have many different opinions. And I think all of us would agree that the patient should be the primary stakeholder, but these other people play a role. And so I think it'd be very hard ultimately, even if we have perfect data, to identify an optimal workload that is optimal for everybody and certainly is applicable in all ICUs in all environments. With all of those caveats, let's go through what we do know. So I want to break down the components of intensivist workload into sort of 2 buckets. And I think of this sort of like the heart rate and the ejection fraction, kind of a dumbed down version of the talk we saw earlier today. So how often do I do my job, the heart rate, and how hard is my job when I'm doing it, the ejection fraction, right? And we're gonna start with the top. And when we talk about how often one's doing their job, it's what do the shifts or the work days look like? Are you doing them on the weekends or overnight? Are you working, how long are your shifts when you do them? And then how many are you actually doing during the year? And I'll show you what we know. So there have been some randomized control trials, and these are two examples actually very well done by Dr. Garland and his colleagues now currently out of the University of Manitoba in Canada. In this, they did a cluster randomized trial of 5 ICUs in the United States, medical ICUs in the United States, in whom they randomized units to be either their traditional staffing model, which was to take care of patients for half the month contiguous days. They were there during the daytime. They received phone calls overnight for any questions that the staff on site had. And then their intervention group was, instead of having the same provider be there for the full half the month, they were there Monday to Friday, and they had a colleague relieve them, so to speak, on the weekends, to give them, quote unquote, the weekends off. Overall, if you looked at the number of days everybody worked, they worked pretty similarly. Right now, they were just doing the weekends at different times. And what they found was that there was no impact of this intervention on patient outcomes, but they saw a notable and sizable decrease in physician-reported burnout and an improvement in home life balance when they were given the weekends, quote unquote, off. And again, this does not mean they were working fewer overall days, they were just structuring it differently. Similarly, the same group did a different study looking instead at weekend breaks, so to speak, but at nighttime breaks. And so this was a cluster randomized trial in Canadian medical and surgical ICUs, 2 of them, in which they took their standard model, which at the time was 7 days in a row of daytime coverage by a single intensivist, again, taking home call at night whenever, so being woken up throughout the night as needed, and had an intervention group that instead they randomized to be the same person daytime during the day for 7 days, but a colleague covering at night in-house. So that they were, the daytime person was sort of given an opportunity to rest, relax, recharge, so to speak. They actually found decreases in hospital length of stay, but no other differences in patient outcomes, most notably things like mortality. But again, they found improvements in burnout scores and betterment of home life work balance. Interestingly, though, when the nurses were queried, the nurses reported more of what they described as role conflict. They were a little unsure who was in charge, right? That not always the intensivists on in the day and the night did not always have the same opinions on how things should be done, and they weren't really sure who they were sort of supposed to be listening to as the leader of the team. And similarly, and I think not surprisingly, many of us probably have felt this as many of our ICUs, at least in the States, have incorporated this 24-hour in-house senior physician coverage, is that the trainees often felt that they had less autonomy at night. That may or may not be a good thing, but that was their perception. And again, I just want to show you that, and I think many of you may know this data, that the findings of this study and the impact on patient outcomes are not unique to this one study done by Dr. Garland's colleagues. So this was a meta-analysis led by Mitza Kurlin and sponsored by the American Thoracic Society, published a couple of years ago, in which they looked to answer the question, do intensivists on-site overnight improve patient outcomes? And so I'm just showing you here the forest plot that looked specifically at the outcome of hospital mortality. And you can see that they've divided the different studies into those for whom the daytime ICU coverage was what they considered quote unquote low intensity. Usually that meant that an intensivist was only involved as needed or not at all, versus the ICUs at the bottom where people were in ICUs where the intensivist either assumed care of all the patients or was a mandatory consultant. And in both groups, and most notably across all studies, they saw no statistically significant difference in the odds of death at hospital discharge associated with the initiation of nighttime intensivist coverage. And so this is a pretty well done meta-analysis, and we sort of thought maybe would answer the question, so to speak, once and for all. However, as many of you may have seen, there have been multiple sort of perspectives and debate articles about this topic even after this was published. And so this actually is one of the pieces that was published this past year in Critical Care Medicine, in which these authors argue that despite this evidence, and they refer to this study specifically, they feel there's significant benefit of 24-hour in-house intensivist coverage, at least in specific settings. And they make the comment, and again, this may or may not apply to the environment in which you guys find yourselves, but that certainly in a place like the US, there is, an ICU is not, all ICUs are not the same. One ICU is not the same as another. And so we have a large number of what they considered low acuity, low volume ICUs on the left-hand side, and a smaller but significant minority of high acuity, high volume ICUs, which again probably look more similar to what many of you are used to and tend to be clustered in our tertiary quaternary care centers. And what they argued was that the benefit of a nighttime intensivist was not to improve mortality across all ICUs, which is exactly what Dr. Kurlin's study had investigated, right? but rather that it was to provide improvements in care processes overnight that would be specifically beneficial to ICUs that had high acuity, high volume. And in specific, they give examples of things like nighttime rounding, off-hours extubation, improvements in timeliness of goals of care discussions, and they cited several studies that had been done previously suggesting that overnight intensivists may actually lead to some of these outcomes. And I think that that's an incredibly important point, but I would caution us all to remember that just because processes of care are improved or changed or expedited, and we think they may be good, we better look at that before we decide. So I'm just going to draw your attention to two examples. This is a study, that I was able to lead that we published a couple of years ago, looking at data from a data set in the United States. In which we were able to identify the time that patients across general medical surgical ICUs were extubated during the daytime hours or nighttime hours. And we compared the outcomes of patients who were extubated overnight to those who were extubated during the daytime. As you can see on the left-hand side, these are patients where it says mechanical ventilation duration less than 12 hours. Those are patients who had shorter durations of mechanical ventilation, and on the right-hand side, those with longer than 12 hours of mechanical ventilation. And in both groups, you can see that there was an increase in mortality, both at ICU discharge and hospital discharge, associated with overnight extubation. So although we may expedite this process of care, I think we need to be careful before we decide that that's a good thing. Now again, this is a retrospective study. We did everything we could to adjust for confounding factors, but it certainly is not a randomized prospective study, and certainly more study is needed before we can say it's really unsafe to do this, but it probably isn't something that we should be rushing to support. Similarly, this meta-analysis was published a couple of years ago looking at the impact of nighttime discharge. They looked at several studies in which patients were discharged either overnight or during daytime hours, and what they found fairly uniformly, and certainly on meta-analysis, was that there was a statistically significantly increased odds of death associated with being discharged from the ICU overnight. So again, having an in-house intensivist may facilitate ICU triage and patient flow, but that may or may not be a good thing. Okay, so I'm going to pause for a second and just summarize what we reviewed thus far. So in terms of staffing and in terms of how frequently someone works, it's possible that smart scheduling of intensivists, particularly with an eye toward weekend and overnight scheduling, may be beneficial to the intensivist without having negative impacts on the patient. And that although having 24-hour intensivists may expedite processes of care, we probably should pause before we say that full force we think that's a good thing. Okay, so what do we have an idea of what we know about how often we should work in a short term. How about how often we should work overall? Well, this is pretty much the only data that exists as far as I'm aware. This was a survey conducted by Dr. Savransky and colleagues, published a couple of years ago in Annals of the American Thoracic Society. And again, it's a purely US-based study. There is nothing elsewhere as far as I'm aware. And basically what they did was survey people who were part of two ICU leadership groups in the US and ask them if they could report on what the average amount of days, nights, and weekends that their full-time clinical equivalent ICU physician in their institution would work. Okay, so again, it's purely self-report. It is not validated in any way, and it certainly is not compared to outcomes. And what they found, with all the limitations of this study, is that the median number of days, or median number of weeks, I'm sorry, that an intensivist in the US in this cohort worked was about 24 weeks, with about 24 weekend days and no nights. However, as I said, we know nothing. Even if this is appropriately representative data, we know nothing about how this type of staffing impacts or does not impact patient outcomes. Okay, so that's, as far as I'm aware, that's pretty much all there is out there about how often. How about how hard? And when I think about how hard, we're talking about, I think many of us feel, how many people do I care for? Are there new people? How sick are those people? How many people are around to help me out, right? And so that concept has been codified by Dr. Halpern and colleagues and specifically related to ICUs in general, not intensivists in specific, in this concept of strain, which he defines in this paper in Current Opinion in Critical Care in 2011 as a temporally varying influence on a given ICU's ability, in this case we'll think of as an intensivist's ability, to provide high quality care for everyone who is or could become a patient in the ICU on a given day. Right, so this idea that you're not only responsible for the people there, but you're responsible to be available for people who may need you. And in that landmark paper, he identified what he thought of as 5 potential drivers of strain. And again, I think they're things that we would all think about. How many patients do I have that need my resources? How many resources do I have? How many people do I have that can help me do it? How coordinated and efficient are we as a team? And how sick are the people I have to take care of? And although he hasn't been able to look at all of these, his group has looked at several of these particular drivers in strain and how they've been associated, at least retrospectively, with patient outcomes. And so in particular, when they've evaluated the number of new admissions or an overall ICU census, they've seen that they've found that there's been an association of increased mortality with increased number of new admissions or overall patient burden, an increase in the number of time, not surprisingly, it takes to finish clinical work rounds, a reduction in sort of standard operating procedure or VTE prophylaxis, and actually, interestingly, a decrease in the time to do not resuscitate order initiation for those patients who ultimately received a do not resuscitate order. And there's some question about why that might be. But clearly, processes of care and patient outcomes are impacted by these measures of strain. But I think, unfortunately, as we can sort of see when we're thinking about this as a hospital administrator, as one of us thinking about what our daily lives will look like, it's hard to quantify all of these things, right? I know in retrospect how sick my patients were, but it's a little hard to predict going forward exactly who's going to roll into the ICU every day. And when it comes to staffing, it's harder for people to keep all of that information available. But I do think, at least as a starting point, there is a simpler metric that we can use and that our colleagues have been using for a very long time. So I think it is not surprising to any of us, no matter where we practice in the world, that nurses are constantly staffed based on the number of patients that they are required to care for, right? The nurse-to-patient ratio, although it varies quite substantially around the world and within countries, but it is nonetheless a recognized point that nurses should be staffed based on the number of patients they're going to care for. And in particular, this is a meta-analysis from now over 10 years ago, looking at patients from across many settings, including the ICU. And you can see across the board, they found significant improvements in patient outcome associated with having fewer patients cared for by a single nurse. And I would argue that we can do this for physicians as well. And particularly, we can very easily quantify the number of ICU beds or patients that we have and the number of intensivists that we have available to us. And as a result, we can pretty easily, and any administrator who's looking to staff things can easily identify a quote-unquote patient-to-intensivist ratio, very similar to the patient-to-nurse ratio. And there is some evidence that this is associated with patient outcomes. So this is a survey conducted about 5 years ago on the perceptions of the impact of patient-to-intensivist ratio on both providers and the patients. And so this was a survey done of US academic pulmonary and critical care program directors, so directors of our training programs for people who were going into the field of critical care medicine. And they were asked to think about in their ICU what the median number of patients that they would take care of on an annual basis was. And these ICUs were selected, or these program directors were selected specifically because most of our academic hospital settings and not most of our non-academic hospital settings in the US have what we call closed ICUs, right? What you guys are most of the time familiar with, where the patient care is given over to the intensivist. So they were asked how many they had, and as you can see in the upper left in that orange writing, the median number, the median patient-to-intensivist ratio was somewhere between 13 and 14, okay, across this cohort of ICUs. And when they asked people then, unrelated to that median, how do they feel when the workload, how do they feel in terms of their, as providers, do they have enough time to take care of their patients? Do they have enough time to provide education? Do they feel stressed, et cetera? They found an association, I think not surprisingly, with increased stress on the part of the providers when they had more than the median number of patients to care for on an average day, and less time they felt for education. But again, this is just people's perceptions, and it certainly doesn't tell us anything about how the patients do. So there are 3 studies that address that. This one was published out of the Mayo Clinic and was sort of an artifact of a natural experiment. So the medical ICU at the Mayo Clinic in Rochester was undergoing an expansion, and they had started with 15 beds in their ICU, and they were planning to end up with 24. And so what they decided to study was, as the ICU was built and they brought in a second provider to allow for that, how did the outcomes for their patients change? So they had 4 time periods, as you can see on the left. The first was when it was 15 beds and 1 intensivist. They then added a second intensivist before they expanded. So on average, each intensivist had 7.5 beds. They then expanded to 19 beds and then to the full 24. Okay, so those are the 4 cohorts. But interestingly, as you can see on the bottom, and I think this is important, just because you have a bed doesn't mean you have a person in it, right? And it's not very hard to take care of a bed. It's much harder to take care of a person. And so actually, when they look over the periods of time, there was a significantly, a notable difference in the number of patients that each provider cared for when they were 15-to-1 beds. But after that, they were pretty similar, somewhere between 6 and 8. And looking at ICU length of stay, what they found was when the intensivists had more patients to care for, there was an increase in ICU length of stay. They actually saw no difference in hospital length of stay or mortality outcomes. You could very easily argue that patients don't care so much about ICU length of stay. I think we do when we're talking about triage, and hospitals certainly do, but patients probably don't. This second study was done more recently in 8 French ICUs led by Dr. Naraz and his colleagues. And they asked the question, what is the likelihood of a patient dying based on the workload of a given shift in the ICU? And they had many measures of workload for which they adjusted, but 2 of them are listed here. One is the nurse-to-patient ratio, and the other is what they called physician-to-patient ratio. Physician, to be clear, in this study was not just the senior physician. All trainee physicians were included as well. Okay, and what they found, I think consistent with certainly the literature we'd seen on nursing before, was that when you were taken care of on a shift where your nurse had more patients, you were more likely to die. And in fact, as they found, was that when you were taken care of on a shift where your physicians, again, the intensivist and their team had more patients, you were also more likely to die. And I think sort of the end of this information for now, unfortunately, is a study that we were able to publish last year, which was looking at data in the United Kingdom. And this was data from 94 ICUs across the United Kingdom, in which we asked the question whether or not you were more likely to die as an ICU patient if, on average, not in a given shift, your intensivist had more or fewer patients to care for. And what you can see here is that we found a non-linear association between the likelihood of death at hospital discharge and the number of patients you had. So that in specific, if your intensivist cared for very few patients, you were more likely to die until we got down to an optimal number in this cohort of about 7.5 patients per intensivist, after which, again, we saw a worsening of outcome. I will call your attention, I think you can all see the graph on the left, the gray bars are actually the confidence intervals. Once we get past about 12 or 15 patients per intensivist, we lose a lot of confidence, right? There just weren't that many such patients in our cohort. Okay, so I think overall, we know that the concept of ICU strain, I believe the concept of ICU strain may be applicable to providers, that patient-to-intensivist ratio, although not perfect, may be a simple construct that we can use to replace strain for the moment, and that it's important that we consider patient-to-intensivist ratio and maybe a cutoff of 14 or even less in some settings, maybe from what we know now, the right thing to do. Okay, so where do we go from here? So I think the key is to mitigate as best as we can against under and overwork. So ideally, the first thing we need to do is monitor the intensivist workload. We should not just say, I have 5 intensivists and they must cover what I have and therefore we're just gonna do it that way. Is it too much or too little? And specifically ask the intensivist how they feel about their workload. And if it's suboptimal, what might we be able to do? Well, I think the easiest answer, which is a lot easier to say than it is to finance, is to see if you can change the number of intensivists, right? That's great if you can do that. If you can't, might you consider things like scheduling changes that have been shown, again, to maybe positively impact the intensivist, but not negatively impact the patient? Might you be able to reduce or change their non-ICU responsibilities? I think many of us know that when we're in the ICU, in some instances, that's our sole responsibility. In other instances, we might be covering a MET team or being asked to cover in the operating room or outpatient setting. Might there be other staff or even other resources that we could employ to try to offset the workload? And then ultimately, I think, are there operational changes that we can try to improve the flow through our ICU so that practically we are caring for fewer patients at any given time? I think putting that all together, when we look at staffing in 2018, what best I can take away from the literature, limited as it is that patient-to-intensivist ratio probably does matter. I think that shouldn't surprise us. It matters for our nursing colleagues. Why wouldn't it matter for us? Probably based on what we know at this moment, we should target 14 or fewer patients. Again, that's going to depend on your setting. And then in some instances, it may actually need to be fewer than that. Oops, sorry. That full-time, and again, I say likely, that probably was generous. As best we know, this is what full-time looks like in the US. I've been sort of polling my colleagues as I walk around here, and it is very clear that it varies from institution to institution and certainly from country to country, but that's probably a reasonable starting point. And that off-hour coverage almost assuredly improves patient outcome. So I think looking to the future, we have 2 key things that I think could help us advance this field. First, I think it's important that we develop and then validate tools that measure workload. Again, I think patient to intensivist ratio is a good starting point. I don't think it's perfect, and I think we certainly need to do better. And then secondly, I think we really need to evaluate the impact of the intensivist, but stop thinking about him or her as a provider in the ICU in a vacuum. So in particular, to look at the impact that his or her non-ICU responsibilities have, and the impact that his or her team has. And I just call attention here to some of my colleagues, 3 of whom are from Australia and are here in the room as I understand it, and a colleague, Dr. Wunsch, who was here giving a talk similar to this last year, with whom I've had the privilege of sort of setting up a research project that we are hoping to get moving forward to get us some answers for some of these secondary questions. So again, in conclusion, intensivists probably matter to ICU care. I realize that the data is not clear, but I think most of us probably believe that quantifying intensivist workload matters, that a simple construct like patient to intensivist ratio may be helpful, but that workload probably needs to be studied in more detail, that further study of intensivist impact, specifically the intensivist, is necessary, but that despite evidence gaps, we are still going to practice in 2018, and we need to be mindful of workload and not simply staff our intensivists because that's who we have.